Thank you. Hi, everyone. Welcome to our session on Cauda Equina syndrome, an update for the guidance within primary and emergency care. I'm really excited to share this session with you. Great speakers. I hope you'll all agree. We'll play the videos first and then we'll go to a panel question. Please put your questions in the question box. So without further ado, I'd like to introduce Chris Mercer, who's a consultant physio working within primary care. He's recently published a consensus statement document on red flags for serious pathology as a publication. So over to you, Chris.
Afternoon. Thanks for asking me to speak today. My name's Chris Mercer. I'm a consultant physiotherapist based on the South Coast. I work in a spinal clinic and have a particular interest in Cauda Equina syndrome. I've been asked to talk about the front-end challenge, so the challenge within primary and community care settings. Just for a bit of context, we know that patients who aren't well managed with Cauda Equina have significant and devastating consequences. About 20% have very poor outcomes, which leads to poor sexual function, poor bladder and bowel function, but also significant psychosocial and psychosexual problems ongoing. Many of these patients don't return to work, don't return to their normal social activities, so the consequences can be devastating if we don't get this right. We know that the vast majority of cases go wrong at the front end due to a failure to diagnose or a failure to investigate at the appropriate time. As well as the patient devastating consequences, there can be significant consequences for the system and for the clinicians involved. The GIRFT report from a couple of years ago showed a significant amount being spent on CES litigation. It makes up about a quarter of all the litigation in spinal surgery. So it's the largest single condition that is responsible for litigation. But the vast majority of litigation in these cases, nearly 60% of these cases, the patients presented with early signs or symptoms of Cauda Equina dysfunction at their first consultation. So clearly, if we can get that front end managed better, stop these patients progressing from suspected Cauda Equina or incomplete lesions, then their outcomes will be much better and the litigious burden will be much decreased. The cost of litigation has gone up significantly. When last looked at in 2018, the costs were around £640,000 per case, but I've no doubt that those have risen significantly since then. So why is it so difficult? We have fairly standardised, well-recognised features of this condition, but we still don't manage it quite as well as we should do. And there are several reasons for that, I think. One of those is that it's not that common. Whilst it constitutes a large proportion of the litigation, if we're talking about low back pain in primary care, it's less than 0.1%, and even in secondary care, less than 0.3%. And the challenge, I think, is doubled up by the fact that people are anxious about misusing services or sending patients in to the emergency department or to orthopaedics, and for those patients not to end up having Cauda Equina. We know that about 20% of the people that we send in do have positive MRI scans that correlate with their clinical presentation, but that means that 80% don't, and that can be a cause of tension in the system. One of the other reasons for us not getting this right in as many occasions as we could do is that the features of Cauda Equina can be mitigated by lots of other conditions. Whilst most of the information and the diagnosis is gained in the subjective history taking, there are many confounding conditions that might give bladder and bowel symptoms, and those being much more likely than Cauda Equina. It's really important from our perspective that our history taking is targeted. It's really important, and probably the most important thing, is that the patient understands why we're asking the questions, and often this is an issue. Patients in a study by Sue Greenhouse and colleagues, they all remember being asked questions about their bladder and bowel function, but none of them related it to their back pain. None of them really understood why they were being asked it. And similarly with sexual function, patients thought they were being asked if they were sexually active rather than whether there was any change to sexual function. So there's something there around the clarity of the question. There's something around engaging the patient in the understanding of the questions we're asking. The physical tests we have poor reliability and validity, which doesn't help us. A lot of the physical tests are aimed at these two categories, the retention and complete. And a lot of the subjective questions are aimed at the first two categories. And it's these first two categories that we're likely to present in primary and community care. And it's these first two categories that, if we intervene early, are likely to do better. So we really have to do better at improving diagnosis and onward referral in these first two categories to help both with the patient consequences and the litigious consequences. Saddle sensation testing, sexual function, sexual dysfunction are two key areas. We know from various papers, including this one from Michelle Angus and Daniel Horner, that sexual dysfunction is often not asked in the emergency department. Somewhere around 10% of patients are asked. And this is reproduced in other studies in physiotherapy and primary care settings, that sexual dysfunction is often not asked for various reasons. Sometimes it's because of lack of knowledge, sometimes it's because of embarrassment. Perianal sensation is important, both from a subjective and a physical testing side of things. Again, these are sensitive questions, so they need to be framed carefully in the right context, and clinicians need to be confident to do that. From a physical testing point of view, there are issues in primary and community care around chaperoning, and that may not be as widely available as in other healthcare settings. So again, it just needs to be in context, but needs to be managed in a safe, well-governed way. Digital rectal examination has poor predictive value for Cauda equina, and the new National Low Back Pain Radicular Pathway has suggested this isn't used in primary and community care settings, and I think that will be a good step forward once we can embed this in practice. It's been a sticking point. Bladder scanning, in terms of residual volume of over 200 mils post-voiding, does have some role to play in terms of helping to prioritise patients for MRI scanning, but in and of itself, it's not diagnostic of MRIs of Cauda equina. The gold standard is still MRI scan, but this can be part of the assessment tool. So the Venkatesan paper showed the levels, and this Katsaraki paper suggested that bladder scanning was used in part as part of that prioritisation for MRI, but not in lieu of MRI scanning. We know in primary care that safety netting is really important for patients, and these cards, these warning cards here, are credit card sized cards that are written in patient language, following on from the Greenhouse et al. Study. They're very clear. They tell the patient what to look out for, and in this box here, what to do and in what time frame to do it. This card on the left here is a prompt for clinicians, again written in patient-friendly language, for the questions and the frame of the questions around Cauda equina to ask in the subjective history, so may be a useful tool. We've got lots of guidance on how to manage this condition, but it still hasn't landed quite as well as we should hope. The British Association of Spinal Surgeons statement here still holds. There should be a low threshold for scanning, but it should be on the back of good history taking and good examination in a context that the patient understands. We can follow these guidelines we should follow these guidelines, but we don't at the moment. So we need to find a way for primary and community care to embed this better. We know things aren't working particularly well. This entire study tells us that. We know that people are arriving in front of surgeons without MRI scanning. That can't be right. We know that the rates for conversion to surgery are relatively low, and again, that's not efficient. The National Low Back Pain Pathway should help that. It gives clear guidance on the management of cauda equina, and Elaine will talk about that in another talk on this session. So I won't go into details, but it gives really clear advice and guidance around some of the issues that have been challenging. From my perspective, I'm recently appointed as lead for the Primary and Community Care MSK Best Health Programme, and my role is to try and bring together and integrate the management of musculoskeletal conditions with all these other work streams. But particularly in this case, it's going to be important that we work together with spinal services, orthopaedics and the diagnostics to try and help improve management of these urgent conditions particularly. Thanks very much for your time.
Thank you very much, Chris. Don't forget to put your questions in the chat function, and we'll take questions at the end and put them to all the presenters as a panel. So please do put your questions in the chat function. Up next, we've got Professor Daniel Horner, who is going to give us a view from the Royal College of Emergency Medicine regarding Cauda equina syndrome, sometimes a group of people that we neglect to involve in our conversations. Dan's published 2 papers and has one with the EMJ for review at the present time, so has a special interest in Cauda equina syndrome.
Good afternoon, everyone, and thanks for inviting me to talk at BritSpine 2021. My name's Dan Horner. I'm a consultant emergency physician and intensivist from the northwest of England, and I'm also a professor of the Royal College of Emergency Medicine. And I've been asked to contribute to this MDT panel discussion and series of talks to give you a perspective on the emergency department take on suspected Cauda equina syndrome, and also perhaps to talk about future models of care that already exist and are in development moving forward to provide the best care for this group of patients. So where to start? This is, I would suggest, the haystack of low back pain that presents to community and secondary care, and Cauda equina syndrome is just one of the sharp and challenging needles within this haystack. We know from good systematic review data that the incidence of Cauda equina in low back pain presenting to secondary care is around 0.27%. So that's about 1 in every 400 patients that we see in secondary care, and that's probably a career case for a junior doctor spending 3 to 5 years working in our emergency departments. If you want to put this in perspective, then for my tertiary neurosciences and spinal center emergency department, we see around 100,000 patients a year. About 3% of our workload is low back pain. And we tend to send around 10 to 12% of those patients for MR imaging to rule out Cauda equina syndrome. The pickup rate in that cohort is around 10%. So we make the diagnosis around 30 times a year out of the original 3,000 patients with low back pain. And this kind of gives you a headline idea, I suppose, of the challenges that emergency physicians face. 99% of the patients I see with low back pain won't have Cauda equina, and that affects my gestalt and my pretest probability. And it just goes to show that emergency physicians aren't necessarily the experts in this condition, given that we don't see the diagnosis and we don't get involved in the follow-up or ongoing care for these patients. Now, what we would usually do with a condition where the generic symptom presentation is common, but there is a rare diagnosis to exclude, is we'd use clinical features and we'd use clinical decision rules to discriminate who we were going to aggressively investigate and who we were going to push forward for diagnostic testing. But unfortunately, we know that the signs and symptoms of Cauda equina are fairly unreliable. Again, there's systematic review data to suggest that the sensitivity of the common red flag features for Cauda equina is actually very low. And we know that absence of those particular signs and symptoms can't rule out the condition necessarily. This is some unpublished data from the team at Salford who've looked at 1,000 MR scans for suspected Cauda equina syndrome and calculated odds ratios for discriminating clinical features. And what we found was that very few clinical features discriminate, and even the ones that do have relatively low odds ratios, suggesting that although the disease might be slightly more likely with those presenting features, doesn't necessarily rule in the condition. And it has challenges again in interpreting that kind of odds ratio to lead to diagnostic imaging. Some people have previously authored decision rules and Cauda equina scale scores, looking to try and consolidate some of this information. But unfortunately, when they've been externally validated, again, the performance and discrimination is relatively poor. So our usual approach doesn't tend to work in terms of discriminating who needs investigation. And we also see cases that present very atypically amongst these. So these are just some of the published case reports looking at patients who present with bilateral anterior thigh pain, in the one above. And then Michelle and I recently reviewed the literature after an interesting case of isolated sexual dysfunction in the context of low back pain that was brought out through targeted direct questioning. And this just goes to show, I suppose, that we need people with expertise in the assessment of this condition to draw out some of these clinical features and to think about when overall they just have a heightened gestalt for the diagnosis. Because we know if clinical signs and symptoms don't perform well, then we want people who have a good sense of suspicion and target investigations appropriately. And of course, you know all this, and this has been published previously within the SBNS and the BSS standards, setting out how we should investigate Cauda equina syndrome and talking about the limited reliability of clinical diagnosis. These recommendations also lower the bar for investigation through MR, and that's been supported through the GIRFT report in 2019. And all of this is good progress, looking that we should push forwards for easier access to diagnosis and that we should target investigations more appropriately. But how do we best access MR imaging when we need it, and how do we investigate these patients? Well, you could argue that we safety net appropriately and we direct patients to the emergency department for review whenever there are concerns around the diagnosis of Cauda equina. And the pros of emergency department referral are that we're open 24 hours a day, we have good consultant presence supporting the junior staff usually at least 16 hours a day, 7 days a week, and that we have established pathways for imaging in time-sensitive conditions. But there are lots of cons regarding emergency department referral. So without an established diagnostic pathway or referral process, what you're really doing is sending someone to the emergency department to start the clinical assessment process all over again, and usually by a junior doctor without any expertise in musculoskeletal medicine. In addition, we're exposing patients to risk by cohorting them within a department where we will be seeing patients with respiratory illness and with infectious pathologies. And in addition, every set of symptoms has a rare diagnosis within it. So for shortness of breath, that's pulmonary embolism. For chest pain, that's aortic dissection. For headache, that's subarachnoid hemorrhage. And if we tell those patients to go to the emergency department to have that rare diagnosis excluded, then our emergency departments get very crowded very quickly. And that has an established proven link to mortality and certainly to poor patient experience. So we really need to be looking outside of generic emergency department referral for Cauda equina syndrome. What are the other pathways in existence? Well, specialty referral pathways are already recommended. This is a position statement from the Royal College of Emergency Medicine that talks about orthopedic referral to allow patients to hit a hospital bed without necessarily spending much time in the emergency department, and also to have dedicated diagnostic pathways to expedite the diagnosis. And this is one way of approaching the problem, to liaise with your specialty referral colleagues and try and create a process that sidesteps the emergency department. But we can also look to embed expertise within the emergency department within a separate audiovisual area. And lots of centres are already doing this. This is one excellent example from Nottingham, where they have advanced practitioners and spinal physiotherapists who are based in the ED, but will stream patients outside of the main ED footprint to a separate area where they'll undergo clinical assessment. And then these practitioners have same-day access to MR imaging for suspected Cauda equina syndrome. Now, not only does this offer huge benefits in terms of mitigating the risk we discussed earlier, but these clinicians have expertise in musculoskeletal medicine in general. So if the MR diagnosis does not confirm Cauda equina, but perhaps highlights an alternate pathology, then these practitioners are the right ones to follow that up and liaise with community colleagues to ensure that there's continuity of care and that there's a good patient journey without referral, without transfer, without multiple referrals. Now you can take that pathway slightly further, as we have done at Salford, and not only can you embed advanced practitioners and spinal physiotherapists in the emergency department, but you can also create then a pathway where primary care clinicians and physiotherapy teams will refer to that team, and they can facilitate imaging without patients ever setting foot in the emergency department. So this is a flowchart example of how our clinical assessment and treatment service within the community works. And they will liaise by phone with our secondary care spinal physiotherapists if they're concerned about suspected Cauda equina, who will then help process the MR request, facilitate the slot, make sure the patient knows exactly where to go, and then we'll follow up in terms of diagnostics and in terms of ongoing care. And this is brilliant on a patient level, on a department level, and on a continuity of care level. And it is possible, and it does happen. Now, I raised that example, I suppose, to highlight the effect that same-day emergency care can have on patient journeys, but also to try and highlight that this is part of the NHS 2019 long-term plan, and also highlight that the pandemic has really pushed us recently towards developing this model of care. Pandemic medicine highlights that we don't want patients sat in our emergency department waiting rooms together, and we also don't want patients blocking inpatient hospital beds for 3 or 4 days waiting for a diagnostic test to refute a pathology that could be done within a matter of hours if the systems and the processes are in place. So I would urge you all to use this opportunity to sit down with your stakeholders and look at your local referral pathways to see if they can be enhanced or developed. I think it's in the gift of all of us to try and develop those pathways to make sure that patients get the best experience. It is doable, and now is the time to facilitate it and achieve same-day emergency or ambulatory care for suspected Cauda equina syndrome. Thanks again for the invite. I look forward to the panel discussion, and I'm grateful for the invitation to speak.
Thanks very much, Dan. And last but by no means least is Elaine Buchanan, who is the author of the framework for the assessment of Cauda equina syndrome in primary care, and she's going to talk to us about the pathway that's been developed.
An important part of the NHS England Improving Spinal Care project was the development of the National Back and Radicular Pain Pathway, and from this, the National Back Pain Pathway Clinical Network was founded in 2017. We are now one of the constituent societies of the UK Spine Societies Board, and I am so proud that this organisation is flourishing and influencing the national landscape of spinal care. In July of 2020, the network launched the framework for early recognition and referral of Cauda equina syndrome for primary care clinicians. The framework and supporting webinars can be found on the UKSSB website. BAS led the way in developing standards of care for investigation and management of Cauda equina syndrome in secondary care. At BritSpine 2018, the network contributed to a full house, very successful Cauda equina syndrome session. In 2019, Connect Health published a white paper in response to the muddy medical waters related to bilateral leg pain as a red flag for Cauda equina syndrome. It was clear that there was a growing and unmet need for primary care guidance for the management of suspected Cauda equina syndrome. In response to this, the network set up a Cauda equina syndrome working group and had their first meeting in June of 2019. There have been lots and lots and lots of emails and many drafts of this framework. Further consensus was sought at a Cauda equina study day in London in December of 2019. We're very grateful to all who contributed to what has ended up as being a truly multi-professional document. We hope that this document will enhance earlier identification and emergency referral for people with symptoms and signs suspected of Cauda equina syndrome. The final framework was planned to be launched in Glasgow at BritSpine 20, just in time for COVID-19 to hit. Instead, There were 2 webinars held in July, and these were fully subscribed with 500 people and with places and an extra YouTube run afterwards as well. The framework is for primary care and musculoskeletal interface services to use to shape local and regional policies, procedures and pathways for suspected Cauda equina syndrome. It provides guidance on identification, differential diagnosis, safety netting, and emergency referral where signs and symptoms indicate a higher risk of acute Cauda equina syndrome. There is emphasis on communication, documentation, and timeliness of escalation. The launch of the framework stimulated some brilliant questions and comments. A follow-up question and answer session was held by webinar in November of 2020 to address these. The key themes relate to the symptom presentation, assessment, MRI, competencies, bladder scanning, safety netting, and an emergency pathway. I'm sure it is no surprise for you to hear that the strongest themes were anal sphincter examination, bilateral leg pain, what to do when patients attend A&E but are not scanned and discharged, and which service Cauda equina syndrome should be referred to. The problem is that on its own, anal tone testing is not a good test. The evidence is high risk of bias due to low quality. Predominantly, the studies are done in secondary care, but also in tertiary care environments. There are no studies in primary care. There is no controlled testing procedure or inter-tester reliability. Reported anal tone is higher for specificity, but very poor sensitivity. That means that in a hospital setting, anal tone testing is better at ruling out Cauda equina syndrome than ruling it in. And that would be ruling out established Cauda equina syndrome because this is a late sign. There are no studies looking at the clinical utility of voluntary anal contraction, which may be a more useful test. It's also not practical in primary care. The prevalence of Cauda equina syndrome is low, around 0.04%. Although it's not difficult to test, many clinicians have never tested anal tone before or anal contraction before. And many are lone clinicians with no chaperone available. And the majority of clinicians do not have specific spinal experience, which means interpreting the finding is difficult. There are varied views about the usefulness of anal tone testing in a hospital setting, but that is out of the scope of the National Back Pain Clinical Network framework. The problem is that bilateral leg pain is not well defined. The experience of the network committee is that many patients present to primary care with bilateral leg pain. Rather, they have pain in both legs. Many will present with unilateral leg pain, but can have pain in the opposite leg due to other comorbidities or the fact that they're protecting because of the pain severity. And it's not because they've got nerve root compression on the opposite side. Again, the evidence is weak and high risk of bias, and in isolation, the bilateral radicular leg pain is not a good test. The framework provides guidance on pathways for 3 clinical scenarios. Patients presenting with acute or progressive bilateral leg pain with other symptoms of Cauda equina syndrome, and these patients should be referred to the emergency services. You also have people with bilateral leg pain who may have myotomal weakness or dermatomal sensory loss, but don't have any other symptoms of Cauda equina syndrome. And these people should be referred on an urgent pathway. And those patients who have bilateral leg pain but have normal neurology and no other features of Cauda equina syndrome, and these people should be managed as per the radicular pain pathway. There is variance in the emergency pathways in existence around the UK, and this includes musculoskeletal services arranging emergency MRI, to a referral being made to a range of secondary care services. There is no one size fits all. What is in existence will depend on the availability of local services, also the population density and the availability of a major trauma centre, for example. But that would not be applicable to very rural areas where the population density is very low. But the emergency department is the default service where a more robust pathway does not exist. But the emergency department is not a scanning service. The problem with emergency departments is that they're overcrowded. They focus a lot on people who are ill and infectious. And in a time of COVID in particular, you have to ask if this is a good place for people to be asked to go. Because A&E is very overcrowded, it can also result in a delay to the MRI due to the long waits. The doctors seeing patients also have variable experience and may often be junior doctors. What's important is that the emergency spinal pathway is agreed at local and even better at regional level, and the regional spinal networks can be very important in ensuring that an appropriate pathway is commissioned. The National Back Pain Clinical Network experience of developing this framework has been a really positive one, and it has paved the way for future collaborative initiatives. The next steps is to influence a national pathway that applies from first point of contact right through to the spinal surgical services, and that all of our pathways should be endorsed by important bodies such as NICE, NHS England, GIRFT, NHS Resolution, NICE Clinical Knowledge Summaries and NHS Improvement. We very much hope that the implementation of this framework will contribute to reducing the numbers of people who live with symptoms of persisting Cauda equina syndrome. But we must remember that this condition has a devastating effect on the personal and social lives of people who are unfortunate enough to develop it. Many of these are young to middle-aged people who were in work prior to onset. Thank you to all who have contributed. We would like to extend our thanks to BAS for the support in developing the webinars, and thank you for joining this session. Without the contributions of everyone, this framework would not be where we are at the moment. Enjoy the rest of the conference. Bye.
Thanks very much, Elaine. So we're going to go over to Mr. Naveed Yassin, who's going to moderate the questions and hopefully put them to the panel.
Yeah, thanks, Chris, Elaine, and Dan. I think that there's a lot of chat and a lot of questions, and they seem to. One of the central themes is about doing a PR. As we're aware, there's an issue of lack of training, lack of resource with chaperones in the primary care, and lack of experience. But I think one of the common theme that seems to be coming up is concerns about where the legal standpoint of view is, and would these guidelines stand up to scrutiny legally? And is it a question whereby it just shifts the burden towards A&E, where more patients are just sent to A&E because no one's trained to do a PR in the primary care? So, Chris, if you want to start with that. Oh, we can't hear Chris. Elaine?
Hello. The issue in primary care is that you're really asking people who are not experienced with this presentation to do a test that they've potentially never done before. Because in a primary care population, Cauda equina syndrome is actually quite rare. We see a lot more of it in secondary care, and we would expect secondary care clinicians to have those competencies, but it's very unrealistic to think that every primary care musculoskeletal clinician is going to have the competencies to do that. But further, the test doesn't really change whether that patient needs to be referred for an emergency MRI, whatever the regional pathway is for accessing that emergency MRI. And, you know, it's not going to change how the patient's managed. The reduced anal tone is a late sign, but by the time people have reduced anal tone, you really have missed the boat. You should have, you know, got the patient there sooner if there was an opportunity to do so.
Chris? I think Chris is still on mute. Dan, if I could ask you, because one of the concerns is some of the other things we need to consider are things like patients with constipation, patients who've been on opioids as secondary causes for urinary symptoms. And obviously the pathway is not just to treat Cauda equina syndrome, but to treat patients, the 90% who don't have Cauda equina syndrome. Do you think that not doing a PR in the primary care setting will increase the burden on A&E?
So, I mean, I would agree with much of what Elaine said. I'm not entirely sure, you know, that we need to spend all this time talking about PR examination when the literature to date doesn't really support it as a particularly discriminatory test. I wouldn't negate the value of it. You know, as has been mentioned in the chat, there are other bits of clinical information one can glean from a PR examination, and alternate pathologies, as you mentioned, are particularly relevant here. But also, I would perhaps, you know, wait for some of the current research that's happening to come forwards, which suggests already to me that self-reported symptoms around perineal anaesthesia or perhaps perform equally as well as invasive digital examinations. And so if we don't need to subject patients to that kind of intimate tests in order to change our decision-making about whether or not they need imaging, then I think probably what we need to concentrate on is how we get the imaging as soon as we've decided that we want it. And we will all encounter patients when we're in the community in a primary care setting or in a specialist MSK community setting or in secondary care where we think, you know, I want to get MR imaging to exclude Cauda equina in this patient. And it's not going to be sprung on us at any point, you know, so we can have those conversations now to think about how we can offer patients the best opportunity for a quick diagnostic test that doesn't involve them joining the queue of emergency department patients to wait for an intimate exam by a potentially inexperienced practitioner.
Thanks. I think Chris is still having problems with his mic. We can't hear Chris. I think the other question that's popping up is about the fact that UK has the lowest density of MR scanners per population. How can the case for emergency scanning be made unless more scanners are available? And I think it comes back to the same idea of resources. Isn't the problem here one of resources rather than just clinicians' judgment?
There's two things with MRI. The first is that the availability of 24-hour MRI really needs to sit with the regional spinal network. So that would be something for the regional spinal networks and, you know, not really for the National Back Pain Clinical Network framework. So that would out with the remit. But the other thing with MRI is that it's very easy to write a referral for MRI, but what you actually need in the situation of someone with suspected Cauda equina syndrome are people who can actually look at that MRI and safely interpret it and act on it in an appropriate way. So it's not just access to MRI, it's competent clinicians to be able to deal with the MRI findings, because you want to really be able to go on and run with that before the report's even available. You know, if there's something very obvious. It's about ensuring that the pathway to surgery for those with Cauda equina syndrome is as rapid as possible.
And Dan, Chris, Chris, is your mic working now?
Is it working now?
Yes, it is working now.
Yeah, I think the key is just about access to MRI, and I think that there's some work being done nationally around MSK requesting for MRI. So looking to I suppose if we can get appropriate requesting for all specialities for MRI, then there may be a way to increase capacity. That's one way around it, and perhaps the community diagnostic hubs that are coming on stream through this year and through next year may provide additional capacity. But I think yeah, the key is to move people towards to get them in a timely fashion to MRI scan, as Elaine and Daniels have said.
Dan?
Just comment there again now.
Yeah.
So I would agree with Chris and Elaine that access to MRI is a fundamental challenge, and I see it's in the chat as well. I suppose I'd highlight that we've been through this journey with emergency medicine in terms of ambulatory care for a number of significant pathologies. So I remember the day when people used to wait 5 to 7 days for a deep vein thrombosis scan, limited access to ultrasonography. And we pushed that through NICE guidelines, and we used that and the quality standards associated to drive improvements in diagnostics. And now our local data suggests that between 50 and 70% of patients get a same-day scan if they've developed leg pain. So it can be done. It's been done for pulmonary embolism. It's been done for suspected subarachnoid hemorrhage in some areas. Being done for renal colic. So it just needs a significant sit-down and discussion with local and regional and national stakeholders about the benefits of same-day care and the importance of this in the pathway. And just to pick up on something Elaine said, I mean, of course, we do want people to act on the results of the MRI quickly, but the diagnostic images themselves, of course, can be multi-platform. And in the emergency department, after 9 o'clock at night, all of our scans now go to Australia for someone to look at and report quite happily by the beach with a cocktail. And we tend to get verbal reports within an hour for significant pathology in trauma and other cases. So, PACS will make those scan images available to regional spinal surgeons should they want to look at them immediately. But also, the telemedicine is really changing the face of how we act on imaging quickly.
Now, can I just say as well, as the HE looking into the fact that radiography is, there's very few people accessing training to be radiographers, and it is potentially going to be a huge issue if radiographers aren't coming out qualified. So we all need to get into our high schools and tell people to become radiographers.
Mm-hmm. Thanks. I think we've just got 1 minute left, just for one last question, which will be, and this is close to my heart, so Harshad asks that many routine MR scans come back with a report saying Cauda equina compression. And that seems to create a lot of havoc, and that's a huge number of my referrals in spines. And one thing COVID has shown is that the highest domain knowledge clinician should be the first port of call to make the clinical decision. So what's the panel's view about that, and about training those first contact practitioners to be the most skilled in making those diagnoses?
I completely agree with that, because I think people referring for MRI need to have the skills to be able to look and interpret what they're actually seeing and what's on that report. We also need to do some work with the radiologists to try and get them not to use the word Cauda equina syndrome when it's degenerative stenosis. And there's a difference in these presentations. That is not acute Cauda equina syndrome.
And I think it's about the definition, the distinction between compression and syndrome. You may well have compression or effacement of the Cauda equina, but Cauda equina syndrome is people with symptoms. So for those patients, we would safety net those patients, clear safety netting advice. And I think from a kind of FCP point of view, front end point of view, that would be our route really to safety net rather than refer through for spinal surgery.
Right, thank you. Because we've run out of time now, and I think I'm getting messages. So thank you, Elaine, Chris, and Dan, and Michelle.
And Patrick's doing the third Cauda equina syndrome session tomorrow morning, so please do join us for that one with Patrick.